Good afternoon and welcome. Again, my name is Tonya Winders, and I'm the President and CEO of Allergy and Asthma Network. We are excited to welcome you to the 18th webinar in our series of special COVID webinars to address the unique issues related to coronavirus. Over 42,000 people have viewed this series of COVID webinars, and we are in a true moment of change with the COVID vaccine that is newly available. Today's program, COVID-19 Vaccine, Treatment, Trust, and Health Inequities, will address some of the evolving issues and relevant topics. At Allergy and Asthma Network, we remain committed to ending needless death and suffering due to allergies, asthma, and related conditions like COVID-19. And we are honored that more than 2,000 of you have chosen to join us this afternoon. I'd like to begin by introducing our speakers. First, Dr. Leroy Graham. Dr. Graham is a board certified in both pediatrics and pediatrics pulmonology. He is Associate Clinical Professor of Pediatrics at Morehouse School of Medicine and a former partner at Georgia Pediatric Pulmonology Associates. He's the founder and medical director of Not One More Life. It is a 501c3 nonprofit that partners with communities of faith and schools to provide free programs of screening, education, referral, and outcome monitoring to address disparities in the morbidity and mortality attributed to asthma, COPD, and lung diseases in high-risk populations. He's a past member of the Board of Regents of the American College of Chest Physicians and a current trustee of the ATS Foundation. Dr. Graham retired from the U.S. Army Medical Corps in 1993, where he served as a brigade surgeon of the 2nd Brigade of the 1st Infantry Division in Operation Desert Storm, and received a Bronze Star and the Combat Medical Badge. He led the development of the Bridge Atlanta Medical Center as the inaugural CEO and medical director. The center opened in June of 2016 in Norcross, Georgia, as Atlanta's newest charitable health center, uniquely offering both primary and specialty care to the underserved. Next, Dr. Purvi Parikh is an adult and pediatric allergist and immunologist at Allergy and Asthma Associates of Murray Hill. She is currently on faculty as clinical assistant professor in both departments of medicine and pediatrics at NYU School of Medicine. She has been passionate about health policy and serves on the board of directors of the Advocacy Council of the American College of Allergy, Asthma, and Immunology. She travels to DC frequently to help influence policy, testify before Congress, and advocate on behalf of her patients. She is the national spokesperson for Allergy and Asthma Network and frequently makes appearances as the medical contributor for NBC, Fox, CNN, Wall Street Journal, CBS, and more. As a resident of New York, Dr. Parikh has been on the front lines of the COVID-19 outbreak and also served in leading the clinical trials. She has a very unique perspective about the pandemic, and we're excited to hear from her once again today. Welcome, Dr. Graham and Dr. Parikh. As we get started with our time, here's an outline of the topics that we'll cover. First, we'll spend some time, as we always do, looking at the current state of COVID-19. 9 months into the pandemic, I think that it's always good to stop and take a pause in a moment to reflect on the lives that have been impacted. Then we'll turn our focus to the vaccines and treatment, as well as to COVID-19 and health inequities. And then finally, we'll take a fun look at who has already come out publicly and commented on whether they will or will not take the vaccine, and also get some input from each of you. So as we get started, you all know we like to host a poll question. Let's see who's here today. So which of these categories best describes you? I'm gonna launch the poll now, and you can log in your response. Are you a physician, physician assistant, nurse practitioner, nurse, school nurse, respiratory therapist, asthma educator or health educator, or patient? And we know that some of you may cross over, but just choose the category that best describes you, please. As I said, we have over 2,000 people registered for today, so many people on the line. We'll give it just another couple of seconds to collect the votes, and then we'll share with everyone. All right, going to close the poll and share the results. Looks like we've got very consistent with some of our other webinars about the vast majority are nurses and school nurses at 87%, 8% respiratory therapists, asthma educators, and then it looks like about 2% physician, 2% PAs and NPs, and 1% patients today. So a very diverse group, and again, we look forward to getting your thoughts as we go throughout our time together. So what is the current state of COVID-19 as we sit here 2 weeks before the close of 2020? Always we go to the Johns Hopkins Coronavirus Center and their dashboard. And what you can see here is that the global case rate is very rapidly approaching 75 million, with over 17 million of those cases attributed to the United States. As you can see as well, we have exceeded the global death toll of 1.6 million, with over 300,000 of those attributed to the US. This is a very interesting dashboard. Again, you can always look at the active cases, the incidence rate among different demographics, and you can also drill down to the state level if you want more detailed information. But this Johns Hopkins Coronavirus Center really has been our go-to source for tracking the most up-to-date numbers, and this is as of 11:30 this morning. And then we also rely heavily on the CDC for daily case rates and looking at the trends. Unfortunately, we do continue to see the new case rates on the rise, with exceeding that number of 200,000 new cases just in the past 24 hours. When you look at, again, the way that average daily case rate is increasing over the population in the last 7 days, you see that we're right at 65 people per 100,000 that are infected with the disease. And again, the death toll rate, unfortunately, exceeding that 300,000 mark, and certainly inching toward about 3,000 new deaths per day. So we are certainly on the uprise, as we all have heard in the headlines. We also decided to share with you some of the considerations around hospital occupancy, because this is one of the key indicators of how we are managing the disease and the capacity to continue managing COVID-19 as those cases may be more complicated. And what you can see in states like my own home state of Tennessee, where we are 99% ICU bed census, and so those ICU beds are occupied, and we don't have a lot of room for additional individuals that are suffering complications due to COVID-19. When you look at places like Oklahoma, where the rate is now 102%, Rhode Island 103%, you can see why we are so concerned about continuing to take the measures necessary to prevent complications of COVID and increase case rates. Again, when we look at this trend over time, this is always a very interesting chart, because we had hoped that perhaps we would see a slight decline in these numbers over the last 7 to 14 days. But unfortunately, we are seeing those new cases by day continuing to inch up. And so, as I said before, we now have seen the first days of over 200,000 new cases. And when we look at the headlines, as we said at the outset, it's been an exciting couple of weeks since we were with you on these webinars, because the Pfizer vaccine has been officially approved here in the US by the Federal Food and Drug Administration. It was approved for ages 16 and older, and now is actually being shipped and distributed to all states. The Moderna vaccine is actually under review as we speak this afternoon, and we are expecting that that vote should come before the close of the day on the East Coast. And we are going to be monitoring that news, and we'll keep you updated should that alert come across in the course of our time here today. Dr. Robert Redfield, who is the director at the CDC, has certainly warned that we should be prepared. We certainly have the potential to reach over 450,000 fatalities before February 1st. And this will just be days shy of the 1-year anniversary of the first known COVID-19 death in the US. So in 1 year's time, we could potentially reach that 450,000 death rate mark due to the pandemic. And as we come into the latter part of December and our attention turns away from, sometimes the day-to-day activity more to our family and our holiday celebrations, Dr. Fauci has come forward and certainly warned us that this could be even more challenging than what we saw at the end of November. He actually has gone on record to say that no one wants to shut down the holidays, and we know that this is a very critical time, but we can't shy away or walk away from the facts and the data, and that if we don't take the proper precautions, this is going to get extremely challenging and tough for all of us. In fact, Dr. Fauci and his own family will not be gathering for Christmas. He said it's the first time in his 3 daughters' life that unfortunately they won't be together. And he empathizes and certainly feels his own set of pain. As we note here, Christmas Eve is his birthday. And so we're all making those sacrifices. We're all in that same understanding of the need to socially distance and certainly make accommodations beyond what we would normally do during the holidays. So our next poll question, how serious a public health threat do you think COVID-19 poses at this given time? So I'll launch the poll and you can log in your response. Is it not at all a threat, minimal threat, somewhat serious, or very serious? We'll give everyone just a few moments. Just a couple more seconds and we'll close the poll and share the results. Thank you all for participating. We love it when we have well over 1,000 people on the line and these polls come together so quickly. So let's share. So no one says it's not a threat at all. I think we all have come to that realization. 3% minimal threat, about 80% that say very serious, and 16% somewhat serious. So I think we're all getting to this understanding that certainly at this particular point in time and given everything that is occurring, COVID-19 is certainly a public health threat that we all need to be very conscientious and aware of as we move forward in our daily activity. So this is a national poll, a Harris poll that was conducted at the end of October. And you can see that there are some differences in the way that people perceive the threat based on age range. And so again, you can see the darker blue is 18 to 34-year-olds, 35 to 49 in the orange, and then the light green ages 50 to 64 and 65 and older. And so again, I think that mirrors what we saw from our own poll, that everyone is fairly in agreement around somewhat serious and very serious, but our older population and probably those that have some of those underlying diseases are even more concerned. So at this point, I'm going to turn it over to Dr. Parikh, and she's going to share with us some of the updates around the vaccines and treatment. Dr. Parikh?
Hi, thank you so much, and for that extensive overview to catch us up. So on to the vaccines. There's a lot of news that's been coming up. Last week, Pfizer got emergency use approval for limited groups of healthcare workers and nursing home residents, and soon Moderna will follow suit. And I just want to reflect on what a historic time it is. You might be seeing people on the news, especially healthcare workers, weeping or crying as they get their vaccine. And then the reason is it's just been such a trying year, but especially for our frontline and essential workers, having to kind of be on those front lines, have the stress of taking care of their patients, themselves, and their family members. So as we know, one vaccine is in early use. Soon there'll be 2, and AstraZeneca and Johnson & Johnson also have reported that they should be applying in late January for their EUA approval too. So one of the big concerns we've had is enough doses for everyone. So the more options we have, the better. Next slide. So, there's 4 types of vaccine in development, and 2 of the companies have a very similar technology. So both Pfizer and Moderna are using this mRNA or messenger RNA vaccine, and that is 2 doses apart. And, it's a really interesting technology in which it teaches your cells, how to make a protein that triggers an immune system response rather than using any live or dead virus. So it's really a unique technology. And, Tom Frieden, who used to be head of the CDC, used a great analogy yesterday, that a lot of people are concerned, what about this mRNA in my body? But he likened it to a Snapchat message, for some of the younger listeners. Basically, you get instructions, but then they disappear. This mRNA is not staying in your body forever, wreaking havoc, but it's a really cool way to kind of teach your immune system to mount that immunity without actually having to suffer through getting sick. The other two, AstraZeneca, Janssen, Sputnik, as well as Johnson & Johnson, they're the vector vaccine. So some of these are 2 doses, some are 1 dose. And this is a little bit different, also introduces genetic material into the cells, again, no virus. But the kind of transport vehicle is a little bit different. They use an inactivated cold virus, either from humans or animals, to kind of be that vehicle that brings that information into the cell and gets your immune system to respond. Next slide. So some more types that are in development, but not quite there yet. Sanofi and Novavax, also 1 to 2 doses. This looks at the protein subunit of the vaccine, and it delivers fragments of the virus to trigger an immune response. And Sinovac, which actually is using whole dead vaccines and dead viruses. It's similar to how we get the influenza vaccine every year, which is an inactivated virus. And what this does is, again, that inactive virus won't make you sick, but it will trigger that immunity that we want. And the reason why there's so many different types of vaccines is when we started this journey, we really didn't know what would work, if any. So it's great that there's so many different companies working on so many different options. And as we learn more, we may realize that certain types of vaccines might be better for certain groups versus others. So I always think it's great to have options. So, the main effect in the recent news is basically to increase confidence in basically Q3, Q4 2021 will probably be when we'll achieve that herd immunity. Many are projecting spring, summer of 2021. But, we really need people to take the vaccine in order to get there, because the natural immunity reaching that point from just to reach the herd immunity rate, the amount of infections and deaths and suffering that would occur are paramount. I mean, even with the amount of people we've lost so far, we only have maybe about 1/3 of the population where we need it to be. And to get herd immunity, we really need 70% or more to have that immunity. So again, hopefully the vaccine rollout and adoption is faster than we expect. The good news is that we're seeing that the vaccine provides better immunity than even getting sick naturally. Hopefully we'll see that, in that 3rd quarter to 4th quarter of 2021, that we'll be getting closer to this point. And all of this, again, will be driven by if these vaccines get approval, because again, we can't tell the future, but hopefully at least 2 are there, and hopefully 2 more in the coming month or 2. And then again, this is just early approval, so full approval will come next. The advisory committee on the recommendations, ACIP, is crucial, because even though the FDA clears it, this is the committee that really gives the guidance on what age groups should have it, what people with what types of comorbidities. So they've already started compiling those recommendations, and we'll hear more as the days unfold and more vaccine candidates are approved. And again, those high-risk populations are being targeted now because the supply is limited. So again, those working in healthcare settings with direct and indirect exposure to patients or infectious materials. And it's critical to preserve the capacity to care for patients, because if we lose our healthcare force, who's going to take care of everybody? And then this includes everyone, not just doctors and nurses, but everyone from environmental services, to people who are in transport. Everyone needs to be protected in the healthcare facilities, and long-term care as well. So people who reside in nursing homes, long-term facilities where the spread is fast, and people in these facilities have all the high-risk conditions that can put them at risk for severe COVID-19. So the interim guidance, the initial phase, again, like we said, will be offered to those two groups, and then future recommendations based on vaccine ability. Also, priority will be to those who are elderly, so over 70, and who reside in multi-generational households. Because the more people that you live with, we've seen COVID wipe out, 7, 8, 9 family members. So we want to make sure that, especially if you live with a lot of people who may be carriers or bring it home, that our vulnerable population is protected. And vaccine hesitancy. So this is actually very concerning. This is a large threat to global health. So even if we have availability, it doesn't guarantee that people will take it, and previous research shows that vaccine compliance is variable and inconsistent. And we need, people to get vaccinated and be on board for this to occur. So we need, widespread public educational campaigns, especially regarding the safety and efficacy, which many people are worried about. So, the acceptance rates vary. People currently vaccinated against seasonal flu have a stronger tendency to accept a COVID-19 vaccine, which makes sense. And acceptance for a COVID-19 vaccine among physicians and nurses overall is unfortunately lower than acceptance rates of seasonal influenza vaccine. And I'm noticing a lot of misinformation even amongst my own colleagues. But many people, once they do get their questions answered, especially from a source that they trust, then do get on board. So it's not that this hesitancy is, irreversible. For the seasonal flu, as you can see, majority of doctors take it, 92%, almost 2/3 of nurses, and about the same in the general population. With the COVID vaccine, it's much less, as you can see across the board. And then when people are asked about their children, of course, then it drops even less so. And I understand the fear, the concern, feeling like a guinea pig. And unfortunately, everything this year has been highly politicized. So there's always fear and suspicion for that reason as well. And again, the most common concerns that I hear: quality control, side effects by far number 2, associated illness. Nobody wants to be first, so they want to let everyone else take it first. Some want to wait for next year. Pregnancy is a concern because it hasn't been tested in the trials. And then people doubt the efficiency. They might think it's too good to be true. They want to rely on physiological immunity. I've basically heard it all. But the thing is, unfortunately, the longer that we wait, the longer it will take for us to get back to any semblance of normal. I know the pandemic fatigue is hurting us all, myself included. So again, the sooner people get on board, the sooner we can move out of this. So about 6 in 10 Americans are somewhat or very likely to get the COVID-19 vaccine if it will reduce their risk of becoming infected by about half. And then they're also more likely to get the vaccine, practice social distancing, and wear a mask if they know someone who's contracted COVID-19. And that makes sense. Of course, if you've seen the terrible effects of it, you'll take this more seriously. And the share of Americans who are somewhat or very likely, based on efficacy, it varies, so it depends how at risk they are. It depends on a lot of other factors as well. If they know someone who had COVID, or they had COVID themselves, or an acquaintance. So of course, this is not surprising. All of our experiences shape how we feel about things. And where would you feel comfortable getting a COVID-19 vaccine? So overwhelmingly, people feel most comfortable in a physician's office. Makes sense. It's a familiar place that you know and trust. Hospital was close second. Health clinic or pharmacy is after that, and then it declines as it goes down. And I kind of actually agree with the slide too. I would prefer in a setting that I trusted, in a medical facility, rather than a public place. And for this audience, one of the CDC recommendations is if you do, for the allergic community, it's much better to get it in the physician's office with that, 30-minute observation window that is recommended. And then the social media role, of course, is huge. Individuals can quickly share content globally. People can access you, even misinformation can access you. So unfortunately, it feeds vaccine hesitancy. Somebody was just telling me today that they've been getting these mass texts from Robert Kennedy Jr. about the vaccine. And so it's just everybody can access our phones somehow, which is scary, but then it confuses us more. And, you know, the elephant in the room, this I've gotten a lot of questions on from all of my patients, the reports of allergic reactions in the UK. So again, you know, there have been 2 in the UK, and now, you know, they were reporting that there were 2 in Alaska yesterday. And I just want to give people peace of mind that overall vaccine allergy is extremely rare. You're more likely to be hit by lightning statistically than to have a severe allergic reaction to a vaccine. And we had thousands of people in our trials that had food allergies, medication allergies, seasonal allergies, asthma, and they all tolerated the vaccine without any problem in both Pfizer and Moderna, actually. So, of course, these things happen. The only people we excluded from the trials were people who had history of vaccine allergy. So again, usually it's an ingredient in the vaccine, and this is what we think may have happened in these cases. But I do want to give some peace of mind that the current recommendation is that allergic people can still get the vaccine as long as they are not allergic to one of those ingredients in the vaccine. So that's something you need to discuss with your allergist. And then please also get it in a medical facility and wait for 30 minutes afterwards. And another thing on the news that we weighed in on was about being allergic to a virus. So all viruses can cause allergy type symptoms. You know, they can cause rash, swelling, hives, but this doesn't mean that you become allergic to COVID-19 or flu or anything. We see this a lot in children. It's just your immune system is being irritated or stimulated in a certain way that it can sometimes cause these allergy type symptoms, but you aren't allergic to the virus itself. So again, you know, we need to educate patients. It's key. Education is empowerment. Knowledge is power. And most people, even the very hesitant ones I've seen, once you have a frank discussion with them about their concerns and fears, they are more likely to then want to get vaccinated. So I completely agree with this slide. I think communication is key to solving many of our world's problems. And with that, I will hand it over to Dr. Graham to go through COVID-19 and health inequities.
Well, thank you, Purvi, for that superb presentation. So one of the realities in the background of COVID is racial disparities. And we see here that people of color, Black, Hispanic, and also Asian, have had a disproportionate share of the deaths relative to their population. This has persisted throughout, and in a sense, as you will hear, it reflects a lot of the same trends in general health in our country. Well, one of the things that we need, the antidote, if you will, for this, is we need health equity, or we need to have people able to access and receive quality health on an equal basis. Unfortunately, there are a number of social and economic factors that have to be addressed for this to happen. We have discrepancies, if not frank discrimination, in terms of exposure to stress, okay? People living as minorities, particularly at this time, and the politicization we've had, and other factors, that stress. Housing, there's housing inequity. In our country, housing costs and so forth are inexorably linked to property value. So rich neighborhoods have better schools and they have better housing. Same thing with educational opportunities. We also need to have quality, affordable health care, not just to those that can get private insurance, but all of us. This makes the whole country helpful. And unfortunately, again, with politicization and the attack on the Affordable Care Act, this has been lessened. We also have to look at the neighborhood, or the macro environment that people live in. Studies show that if you're in a poor, impoverished neighborhood with all those stressors, the stress of violence and so forth, you're more likely to be sick from all causes. Finally, we know that a lot of our urban areas are centralized around central traffic corridors or frank industrial parks, where there's increased exposure to environmental toxins and irritants. We know that, and this has been shown very clear in the pandemic, that a lot of essential workers have been damaged because they don't have stable income and job securities. Restaurants open and close and different services in the service industry. And finally, I read an article that for one of the first times since the Depression, there's food scarcity in our country. I mean, there are 40 to 45% in one study in the inner city, people that literally are worrying from day to day that they have enough food to feed their family. So the impact of chronic disease is important, along with other factors on COVID-19. We know that adults age 65 and over have physiologically lower immune function, and they have an increased inflammatory response to infections that is not also maybe helpful in terms of ridding themselves of it, but the organs that heart, lung, and kidneys get damaged sometimes in the bystander effect. They often have complicating pre-existing conditions, and this again is a consequence sometimes of poor health maintenance, most notably the heart, kidney, and lung. And these are made very worse by serious infection. In fact, when I wrote an editorial in one of the pediatric pulmonary journals, I talked to some first-line people, and they told me that early on, the first wave were people that had heart disease, had kidney infection, had out-of-control diabetes, and this was certainly made worse by an infection like COVID. We also know that as we get old, the lung loses elasticity and lung function decreases. So this makes lung problems even worse. We also know that lower socioeconomic status, substandard overcrowded housing, all these things migrate together with harmful environment exposure, limited ability to get the help that you need, and all of that increases the risk of COVID infection. There's also reliance on overcrowded public transportation, particularly with essential workers, as we said. And then our populations are more likely to have inadequate or no health insurance, complicated by limitations in coverage, and again, the weakening of the Affordable Care Act in the current political climate. Well, what are some of the specific impacts? Well, if we talk about weakened immune system, we look at individuals who are undergoing chemotherapy for cancer or other chronic diseases, individuals that have primary immunodeficiency to include, but not limited to HIV/AIDS and other conditions, and those who have received organ transplants where to prevent rejection, they are given drugs that decrease their immune response and thereby their ability to fight infection. We look at the impact of chronic disease and other factors. We know that specifically in this kind of what we're talking about now, poorly controlled chronic lung disease, to include both asthma and COPD, often is associated with reduced lung function. So if you get a serious pulmonary infection, you're going to be hurt and damaged more. You're going to be compromised because you have no reserve. Similarly, with poorly controlled heart disease and hypertension, again, this stress will cause these already deregulated systems to become even more dysfunctional, with the resultant heart failure and a threefold increase in risk of death. We know that poorly controlled diabetes has also been associated with a threefold increase in death due to COVID. Obesity, which is now appreciated to be an inflammatory condition associated with overall poorly controlled chronic diseases, and very recently that the limitation or the blunting of the body's response to severe infection related to obesity. We know that certain neurologic conditions, to the extent that they weaken the whole system, particularly respiratory muscles, things like multiple sclerosis, Parkinson's disease, motor neuron disease, myasthenia gravis, or people that have recently had a stroke. And these weakened muscles that support breathing are compromised, and also the ability to have a swallow that is protective of the airway can be limited. And many of these diseases are, again, treated with anti-inflammatory medications that may unavoidably weaken the body's response to infection. So let's talk about stress. Everybody's stressed right now. Well, if you look at pandemic stress, greater than 60% of Americans say that they are experiencing some mental health concerns given the relentless and long-lasting stress of this pandemic. We know that 1.5 times in terms of females and communities of color are more likely than males and whites to be concerned about household responsibilities, because those women and those leaders are the ones that are trying to maintain stability in their homes in the midst of this pandemic. There's a fivefold increase about concern about career impact and family household responsibilities than non-parent. So when you're in a family, you're literally stressed by the fact that, am I going to be able to provide? Am I going to be able to take care of these responsibilities in the midst of this pandemic? Finally, there's practical challenges, and these are factors that can lead to asthma disparities and disparities in vaccination. And we need to improve this across the spectrum. One is access to care. It makes no sense. We're the largest Western country without a uniform public healthcare system that provides equity in terms of healthcare access. Income, we've talked about this already. Poverty can affect your access in terms of your ability to get health insurance. Low-income patients have to skimp. They have to sacrifice on something, and often this is sadly medical care, including preventive medications. We know, again, for a lot of reasons, people are exposed to various toxins and environmental allergens and irritants. And people with asthma in urban areas, we know by statistics, do worse. And a lot of poor people tend to be clustered around central traffic corridors where pollution is more of a factor. We also know that there's a lot of vermin in these households, cockroaches and mice, which again stimulate allergic reactions. And then finally, the persistence of cigarette smoke and vehicular exhaust. Atlanta's a good example where I spent most of my professional career. You know, it's bisected by huge central traffic corridors, and that's where we saw the concentration of minorities and the poor in terms of living. We also know that education inequality, our schools are not equal, so people don't get the same education about health awareness and health literacy. And then finally, there's language and cultural differences to the extent we're a very heterogeneous country, but to the extent that those things are not addressed systematically, people often don't get the same type of care, aren't understood, and don't understand. So what can we do? We talked about how bad it is. Well, we clearly need to have more access to COVID testing. We need to have expedient reporting. We need to also screen for comorbidities, and I won't read those to you because we've already gone over it. And we want to assist using validated self-assessment. So very proud to participate in the Trusted Messenger program with the Allergy and Asthma Network. This was a partnership with industry that was unbranded, but we were able to go into 2 large churches in the Atlanta area and screen people, not just for COVID with the testing, but look at blood pressures, do an assessment of how well they were getting oxygen in their system, a limited degree of lung function, and validated questionnaires. And we were able to teach people that, you know, if these basic conditions that you live with are not controlled, you're not going to do very well if you get COVID. So we were enhancing functional health literacy. So it's something called the health belief model, and this is important. This is what has to be inculcated or developed in a patient so that they become an active participant. You have to, 1, believe you're susceptible to the health problem, and that the threat to your health is indeed serious, and that the benefits of what we're asking you to do outweigh the cost. And the costs are not always monetary. They may be in terms of emotions, they may be in terms of stress, they may be in terms of resources. And finally, what we want is to have the person lead with a confidence in their ability to carry out recommended actions successfully, particularly at times of stress. And we know that beliefs influence this willingness to follow preventive and therapeutic recommendations. So vaccine hesitancy, the elephant in the room. So studies have shown that if offered a corona vaccine free of charge, fewer than half of Black people and fewer than 66% in Latino people would actually go ahead and do it, according to a survey-based study that underscores the challenge. Well, this is not just ignorance. This is not just you know, what's going around in the hood. This is the fact that these populations have been mistreated. They have been used for experimentation. They have been neglected. They have been studied for diseases that they weren't informed about. There's no trust. And this lack of an inculcation of trust is what is resulting in vaccine hesitancy. And also, as I hear many friends of mine say, it's new. I don't know much about it. So Black Americans have a high level of distrust in the government. Until, you know, this century, we were not treated equally. Okay, and this has made them very reticent to participate in large numbers in COVID-19 clinical trials. They are the most hesitant group to get a vaccine, and this is pointed in that they may be arguably the most needing group to get that vaccine. Skepticism is rising. Blacks are 2.5 times more likely to contract the disease and 5 times more likely to die. So we have an existential problem here that we have to deal with, but there's hope. The National Medical Association's leadership has been very proactive in this response. They have, from the time that the American Medical Association, which was segregated to physician participants as late as the late 60s in this country, the National Medical Association has always been there for Black physicians, but also for other physicians of color. They represent African American patients and their physicians. They've established a task force to review the findings of the vaccine, and Dr. Leon McDougall, based on that review, who's the current president of the NMA, has said that he will get vaccinated himself when the task force signs off. He also said that vaccine developers have generally supported efforts to diversify their trial participants. And I've seen some of that data, and indeed, in my career in medicine, 40 years, it is some of the most diversified patient study populations I've ever seen. But we could still be doing more to build long-term relationships in communities of color beyond this pandemic, because we're suffering disparities because we haven't done it to this point. So we've got work to do. There is no question, as my colleague said in the preceding thing, we need to get to 65, 75% of our population either being immunized against this or having had it to establish the so-called herd immunity or national immunity to COVID-19. And the challenges clearly lay at the foot of trust and the need for vaccine uptake. And it will take all of us. So one of the things I'd like to say, of all of you that are listening here, tell at least one or two people if you learned something that might inculcate that trust that we need. Next slide.
Wonderful. Thank you, Dr. Graham, and also Dr. Parikh. Very insightful and so helpful. So let's take a moment. Again, I want to remind you, you can enter your questions into the control panel. We'll get to those in just a few moments, but let's take just a moment and look at who has decided to take the vaccine or perhaps who is not. So this again is a nationwide Harris poll, over 2,000 responses, and you can see that there is a difference of willingness, whether it be unlikely, cautious, or interested in the vaccine. And so the pink is those that are unlikely to get vaccinated out of all the responses. Those that are in the light blue are the cautious, where they want to wait that 3 to 12 months or wait until they fully have confidence that it's safe to take the vaccine. And then the darker blue areas are those that are more willing to step up and get the vaccine very soon after coming to market. And then the darkest blue area are those that are actually interested in volunteering and participating in clinical trials. So as we've said before, there are testing fears. There was a recent article that was published by McKinsey that reported 74% of Americans believe that they needed, who believe that a coronavirus may not be needed, that they needed a coronavirus test, chose not to get one or delayed getting one. So they thought they might need it, but they chose not to get it. And some of these respondents were saying that was because they were concerned that they might become infected with the virus in the process of simply getting the test. Over 60% had delayed their in-person care for those underlying chronic issues that Dr. Graham and Dr. Parikh have talked about today. 53% said that that delay was out of fear of COVID-19, and 33% said that they plan to only resume routine care once a vaccine is available. So what we're seeing is twofold. We're seeing people who are not going to the doctor even when they need to manage their chronic condition because of the fear of COVID-19. And we're also seeing people who are fearing getting tested because of how that may impact their health and their life in the immediacy of the current time. This is a very powerful quote here that says, with the vaccine likely not making its way to the general public until spring in the earliest, the healthcare community needs to do a better job of helping Americans get back to routine care. Early diagnosis saves lives, and we know that putting off preventative care and chronic disease treatment could make the difference between life and death. Chronic diseases take a toll on many people's body each and every day. Delays in diagnosis, delays in treatment will cause for many people irreversible damage. This will require more aggressive and less effective treatment and could potentially lead to higher death rates. It's like Benjamin Franklin once advised, an ounce of prevention is certainly worth a pound of cure. And so this is why we are concerned that people not delay that routine care or not completely take control of those underlying conditions. So who is taking the vaccine? First, our three most timely former presidents are committed to taking the vaccine. In fact, Bill Clinton, George Bush, and Barack Obama have all agreed that they will be taking it. President Obama actually said that he might actually do that in public on television, that if Dr. Fauci says the vaccine is safe, that he believes that, and he's going to step up and be one of the first to take it when it's appropriate and timely. Secondly, of course, the director of the National Institute of Allergy and Infectious Disease, Dr. Anthony Fauci, who we've heard from throughout this pandemic. He has said that now that the Pfizer vaccine is approved by the FDA, that he will likely take it. He says, I'm going to look at the data, but I trust Pfizer, I trust the FDA, and I'm ready to take the vaccine when it's available to me. Now, there are others who have different opinions. We've been working with Montel Jordan, who is a pastor, musician, and a marriage expert. And he says, I'm still kind of researching the pros and cons of taking the vaccine. I honestly see that there are some conflicting messages regarding the success rate and how it's been reported in the media. And there's also been some politicizing of the vaccine. And, you know, he felt that again, that it shouldn't be viewed as a Republican or a Democratic rescue, but rather as a human response. And he also shared that he had some concerns thinking about undisclosed and unfair experimentation on people of color, like the Tuskegee experiment that Dr. Graham talked about before, that it's led to some of that medical mistrust. And so he, you know, very clearly articulated that he would be open to a world approved vaccine opposed to this American created vaccine that sometimes does cast a concern of racial bias within our nation. And he was very honest to say that he had trust issues, and we respect that. We know that this is a reality. We know that there are sins of the past that certainly are shaping our current environment. And I think that this final statement by Montel that says, my no is not a forever no, it's just the current stance of after having read the literature and seen what I've seen. So not no forever, but at this particular time, Montel said he's not ready to be the first in line. What about the head of the American College of Allergy, Asthma, and Immunology, one of the foremost professional medical societies in this space? Their immediate past president, Dr. Alan Meadows, says 100%, I will get the vaccine. That certainly he does not feel the vaccine was rushed to market or that the red tape was shortened, that he does assume that theoretical risk, but that he believes that the chance of immunization is much greater than the risk associated with it. Also, the medical director of the Office of Equity and Diversity at Children's Mercy in Kansas City, Dr. Bridget Jones. Dr. Jones has stepped forward to say, yes, she is a mother, a wife, a daughter. She feels that she owes it to herself and to those that she cares about to protect them. And so she will be getting the vaccine and certainly hopes to decrease her risk of getting the virus and spreading it to others. She's done some of the work at NIH and FDA and trusts that dedicated staff that they have gone through the rigorous structure within those agencies to approve these agents. And then our very own Dr. Parikh and Dr. Graham, they both have shared their own journeys here as far as being enrolled and participating in the clinical trials. Dr. Parikh has shared in past webinars that she actually enrolled her own parents in the Moderna trial and felt very positive about that. And then Dr. Graham, of course, has shared even today that he has some underlying comorbidities and risk. And so he takes the necessary steps to take care of himself with exercise, but plans also to get the vaccine when he is able to do so. We've got patients and families on the line, even families like the Nelson family. Wayne Nelson is the lead singer of Little River Band, and he says he'll be taking the vaccine because he feels like it is important to slow the spread. But interestingly enough, he's married to Rhonda, who is an AERD patient that is within the network, and she actually has thought long and hard and has decided that at this point, given her underlying health conditions and some of her concerns, that she's going to wait, that she's not comfortable with taking the vaccine in light of the safety issues with the current biologics that she's taking. So for me, I too am a mom and a patient advocate in lung health, and I believe that taking the vaccine will take a step forward in keeping my own family and my own community safe. And I feel like that this is one small step that I can take to stop the spread and protect the people that I care the most about. And so definitely that includes all of you on the line who've been with us walking through the journey of the pandemic over the last 9 months. And so as soon as I am able, I will also be in line to take the vaccine here in my home state of Tennessee. So now let's go to our final poll question before we go to our Q&A time. For those of you who are on the line, well over 1,000 people, are you planning to get the vaccine when it's available for you? Let me launch that final question. Whoops, sorry. And go ahead and log in your response. Yes, no, I'm not sure, maybe, but I still need more information. And again, no shame here. We know that there are differences of opinion on the vaccine. We just want to provide you all the latest information and evidence and have you all make your own decision, because this is a very personal choice. And we know that, again, we need to reach that level of community immunity or herd immunity that Dr. Parikh spoke about. But we do know that there are many factors that are driving people's decision in taking the vaccine. So we'll leave it open for just one more second. Looks like we've got about 3/4 of the vote in at this time. So we'll close the poll and share the results. Looks like that the overwhelming majority, about 58%, will be taking the vaccine. 11% say no, they've made the decision not to get the vaccine. 14% are still somewhat on the fence, and 17% maybe, but I need more information. So actually about 30% that say not quite sure, maybe need more information, 60% that say yes, and then about 10% that have made the decision no. So again, we really appreciate your honest feedback here. It helps us as we continue to craft, you know, and bring forth interesting topics and evidence to help keep us all better informed. So at this time, I'm going to go to your questions, and really appreciate those of you who have put those in the chat. Let's see. So the first question goes to Dr. Parikh. Dr. Parikh, what happens to the mRNA if it doesn't stay in the body for too long?
Sorry,
Dr. Parikh,
having trouble unmuting. Yeah, I'm here. So basically, the mRNA, it breaks down and it clears out of your system. So there's something called a half-life, and that's the time that it takes for anything that you take to leave your body, any medication. So for mRNA, half of it is gone. Its half-life is within 5 to 7 days, and then another 5 to 7 days after that, another half is gone. So as you can tell, it degrades quite quickly, and that's one of the reasons why some of the vaccines like Pfizer have to be kept very, very cold, because it actually is very transient, and it does degrade quickly. So with anyone who has those concerns of this staying in my body forever, it's just not true, which is great. You know, so there's less likely of long-term issues if something clears out of your system that quickly.
So the next question comes from Stephen, and is one that we've heard concern over. Do you believe that it is legal, or can the government actually mandate the vaccine be taken? Not sure who wants to take that one.
I could start with it. You know, regarding vaccine mandates, currently there are none, because we don't even have enough supply for the people who want to get the vaccine. You know, even amongst our healthcare workers, I know many of us are anxiously waiting our turn. So those mandates, I think, one, would not come into place until there was enough supply for everybody. But, you know, vaccine mandates do exist, especially in settings such as schools, some colleges, even in healthcare settings. You know, Dr. Graham and myself are required to provide proof of flu vaccination or exemption every year. So, you know, there might be certain instances where you would be required. And the reason why it could be legal is because you could be posing a threat to other people, you know, especially with a virus as deadly as COVID-19. For you, it might not be so bad, but you are at the risk of infecting someone who's quite vulnerable, and it could be deadly for them. So that, luckily, you know, that bridge hasn't had to be crossed yet, but I think that will come up down the road.
And then another question about the side effect of Bell's palsy. How frequent is that you've seen in vaccine candidates?
Right. So, you know, that's another question I get very frequently. So I actually personally have not seen it in the people that we vaccinated. However, we did not feel, both in Moderna as well as Pfizer, they had incidences of Bell's palsy, but it wasn't felt to be related to the vaccine, because in order for something to be caused by a vaccine or any medication that's being studied, it has to occur at a higher rate or a higher frequency than normally occurs. So Bell's palsy in general is not that uncommon. We do see it frequently. We see it a handful of cases amongst every 100,000 people or whatnot. So in the study, it still occurred at the same frequency that occurs in the general population. So again, you have to remember that even though people go into studies, their other medical problems do not cease. So things will occur to them in the study, but would have occurred anyway, whether or not they would have been in the study. So you have to really interpret all of this data with a grain of salt. So when the trial reviewers say it's not related, that's generally why, because these are all things that occur on a routine basis that would have occurred in or out of the study.
Very helpful. And would you just go ahead and clarify one more time about those that have known food or medication allergies and their ability to receive the vaccine? Because there is still confusion around that in the chat.
Right. So currently, if you have any food or medication allergies in the US, I know the UK may be different, but in the US, you can still receive the vaccine as long as you are not allergic to any of the ingredients in the vaccine. So one of the ingredients, which we think was the culprit, we don't know for sure, is something called polyethylene glycol, which some people are allergic to, and it's in a lot of other medications and things like that. So if you have an allergy to that or another component of the vaccine, then you should not take it. But if you do not, and you have another type of allergy, so let's say a peanut allergy or asthma or otherwise, you can still take the vaccine, but you should do it in a medical facility and wait for at least 30 minutes afterwards. Those are the current recommendations for people with allergies. So it's not as broad as we initially thought. With the UK, they said no one with allergies should take it. So that's not the case here. And again, keep an eye out, because these recommendations will evolve as we learn more.
Yeah, very helpful. Now, this is a question that has come up quite a bit. If you've actually had COVID-19, should you still get vaccinated?
Yes, my gut instinct is absolutely, because immunity from COVID-19 is very variable. I have even people that I know that had antibodies in June that no longer do now. We have seen cases of reinfection, and people are worse the second time around. So absolutely. But the one thing is, you should not be vaccinated if you're actively sick with COVID or still recovering from COVID-19. So ideally, you want to be back to your baseline before you get vaccinated. For any vaccine, you shouldn't get it when you're sick. So in some of the studies, they did look at people who had previous COVID, and they did receive the vaccine 90 days later and are doing well.
Okay, very good. Now, there has been some, especially in the social media, concern over infertility issues with the vaccine. And so could you clarify if you've seen anything about female sterilization from the vaccine?
Yeah, no, so there isn't any. I know there's a lot going around about infertility, but no, there's no evidence that it causes any infertility. Interestingly, for males, there is evidence that if you get the actual virus, COVID-19, that it can cause erectile dysfunction. So if anything, you'd want to get the vaccine to prevent getting the virus and having that complication. But we've seen no evidence of infertility. Actually, the National Organizations for Obstetrics and Gynecology are recommending it to pregnant women because they're at higher risk of severe COVID-19. And many women of childbearing age were studied in the trials as well. And personally, I plan to have a family, and I also plan to get the vaccine. So
thank you for sharing that. Yeah, that's very reassuring. Thank you, Dr. Parikh. Now, one final question that we have time for, and this is one that has come up a good bit as well. So many patients that are immunocompromised are on biologic agents. We have one particular patient here who is on Humira for psoriatic arthritis. Should people on those type of biologic agents be able to take the vaccine?
So yes, again, we would recommend it, because you're on biologic agents, you likely may have a condition that puts you at higher risk of having COVID-19. So you, of all people, should definitely be protected. We haven't found any contraindication that it would be hurtful to take both the vaccine as well as being on the biologic agent. And even in the studies, we let people who were on whose either autoimmune or allergic conditions were stable and on many agents, they were able to be in the studies as well. So just so you know, it is a high-risk group that needs the vaccine.
Very helpful indeed. And again, I wish we had more time for more of the questions. We will be collating these and putting them back into our FAQ at our COVID Information Center. But I really just want to thank you all for listening and participating today as we looked at COVID-19 and definitely some of the health inequities around the vaccine specifically. I do also want you to consider joining us for the next webinar in our COVID-19 webinar series, when we'll look at COVID-19 in 2021, ringing in expectations for the new year. Dr. Purvi Parikh and I will get our crystal balls out and try to give you some expectations and predictions around timing and the way that this will impact the new year. So again, mark your calendars, January 7th at 4 p.m. Eastern, and you'll be able to register at the webinar page on our website. Again, I just want to thank Dr. Parikh, Dr. Graham for joining us, for all of their expertise today. I am Tonya Winders. On behalf of the staff at Allergy and Asthma Network, we want to continue to bring you the most current information available during this COVID-19 pandemic so that we can all continue to breathe better together. We wish you and yours a very happy holiday season and blessed day. Take care.